Everyone. Thank you for joining us and thank you for your patience as we got set to go live this evening. My name is Megan Lear and I work with the marketing team at UMHS, and we're so happy that you could join us tonight. Over the last few months, UMHS has hosted a series of discussions that are intended for current and prospective medical students, and we've invited various UMHS alumni to talk about their experience working in different specialties of medicine, everything from psychiatry and cardiology to working as an OB-GYN. And these discussions have really resonated with a lot of the people in our audience. And so we wanted to continue with that series of discussions by hosting another event tonight that is focused on what is an anesthesiologist. And we are very pleased to welcome two UMHS alumni, Drs. Andrew Letayf and Dr. Jay Kumar. Both of them are classmates from UMHS, graduated in 2014, and are lifelong friends. And so we're so happy to welcome you both tonight.
Glad to be here.
So we're going to start with some introductions. Dr. Kumar, if you could start us off by telling us a little bit about your journey to medical school.
Yeah, so hi everybody. Thank you for joining us. My name is Dr. Jay Kumar. So I am a board-certified interventional pain medicine specialist, as well as a board-certified anesthesiologist. It's important to say that first before I go through that journey, I figured. So I started at UMHS, I think, August 2010. Went through that whole process, obviously of any type of school. For 6 months are rough, and then you learn as you go, and you get better and better and better, and you gain more skills every year that goes by. Did clinicals, went to Maine, then did clinicals for 2 years while the boards in there sprinkled in and around that. And then started at Wayne State University. I matched at an anesthesiology, and then started at Wayne State University / Detroit Medical Center in July 1st, 2014. Then finished that. I did a pediatric anesthesia fellowship at Children's Hospital of Michigan. And then I did a interventional pain medicine fellowship. And then after that, I took my first job out of training under the Duke Health umbrella. I had my own outpatient private or outpatient practice for pain medicine. And I had a nurse practitioner, full staff, and it was underneath the Duke Health umbrella, and it was a beautiful name and a great place. And then on June 20th, 2022, I started my own practice in my hometown. It's called Spine and Pain Specialist of the Carolinas.
Great. Thank you. And could you just give us a little bit of insight into why you chose UMHS and how you ended up at UMHS for med school?
Yeah, so during the whole application process of being an undergraduate and MCATs and so on and so forth, I was debating between going through DO school or at the same time, I actually, on the basement of my biology building, there was a tear pad where it was a UMHS little flyer, and it was on the bulletin board. And I remember tearing one off and mailing it, putting my info. So at this time, it was also application time for school, and I I went to go visit UMHS as well as some of the neighboring places, meaning the neighboring medical schools on the other islands. And if you would like, I can go into detail, but because of what I compared it to from seeing the other nearby Caribbean medical schools and seeing UMHS, it was almost like a no-brainer, to be honest. And the best statement I can give you is actually my dad's, and because he came with me. And it was the aura, or even looking at the students' faces that were walking around the campus of St. Kitts, comparing it to the other medical schools and seeing those students' faces. He was like, you need to go here. That's a true story. So, yeah.
Awesome. Thank you. And Dr. Letayf, welcome. Same question. If you could tell us a little bit about your background and your journey to med school.
And not to bore you all with the dates because they're pretty much identical to Jay's, although I started in the September, I believe it was the September semester. I did my medical schooling at UMHS proudly, and I later did my residency in Detroit at DMC with Jay, and then did my fellowship in pediatric anesthesia also with Jay. So me and Jay, as you could tell, have been see things eye to eye, and we've been side by side the entire journey. And yeah, after the island, we all go to Maine for that semester, where we sit down and study really, really hard. And then after that, you get into your clinical rotations, where I did majority of mine in Atlanta, but I also was able to do it in Detroit, which is also, I guess, my second hometown. And yeah. That's my story.
Awesome. And you have a little bit of a unique background in that you were an international transfer student for college. So I was just curious if you could walk us just briefly through that and what brought you to UMHS.
So I was born in the United States. I was born in Michigan. And when I was around 10 years old, my parents decided to move us back to Lebanon, Beirut, Lebanon, in the Middle East, where I did majority of my education. I did 2 years at the American University of Beirut, a very good university, very challenging university. And unfortunately, in 2006, the summer of 2006, there was a war in our country, which led me to have to flee the country. And luckily for me, Wayne State University, where I graduated from, accepted me with wide open arms, didn't make me have to repeat anything. And you know, I think that was one of the issues I had when I was applying to American medical schools. The curriculum is very different in the Middle East, especially at the American University of Beirut. It's extremely difficult. So if you get, say, 75% average, that's actually considered an A in a lot of American schools. So I was around the 70%. So I was a A minus B plus kind of student. I thought that I'd easily be able to get into an American medical school, which did not happen. So instead of having to wait a year and reapply all over again, a lot of the guys were telling me about, Caribbean medical schools. And again, I'm coming from a country where to us, you would never think that the Caribbean islands actually provided medical education. In fact, I thought it was kind of a joke, but then they're like, no, man, this is real. And they're very good schools, not all of them, but most of them. And I really looked into it. And like Jay said, my dad, who's an anesthesiologist himself, told me, why don't we get on a plane and go interview there and see what it's all about. And I was just shocked at the, amount of, it was state of the art. And I couldn't believe it. But the difference is that you have this beautiful ocean in the background, beautiful weather, you're on a Caribbean island, but the medical school itself with all its utilities and infrastructure, it's just unbelievable. It was a no-brainer, just like Jay said.
Perfect. And I think it was mentioned earlier that you both have the distinction of being the first UMHS graduates to match into anesthesiology. So Dr. Letayf, you mentioned that your father is an anesthesiologist. When did you decide that that's what you wanted to specialize in?
Well, right after I said that I wanted to be an Air Force pilot at 10, my dad's like, nope, you're going to do anesthesia. No, I watched my dad as I grew up, and I loved his lifestyle. I loved, all the stories he would tell me. When I was 13, he used to take me to the operating room back in Lebanon at the university hospital. And I fell in love with having the ability to know pretty much everything about our patient. And to be honest, to be the most important person in the room and have that responsibility. And at the same time, not knowing, and a lot of people don't really know what we do. You're the guy that puts the patient to sleep. I'm like, yeah, I'm okay with that if that's what you think. But there's a lot more that's involved. It's just, I always compare it to a pilot. All we look at is the pilot takes off and lands the plane and just puts it on autopilot. But there's a lot more that's going on there. And, our lives are in the pilot's hands. It's the exact same thing with anesthesia. So my dad kind of showed me that. And yeah, and I've always wanted to. And in fact, I've always wanted to do pediatric anesthesia ever since I was 13. So, yeah.
That's great. And how about you, Dr. Kumar? Curious when you knew that that's what you wanted to do?
Yeah, I've answered this question a lot, and really the best answer I have is, in high school, just like any person that's interested in perhaps going into the healthcare field, I shadowed like ninth, 10th, 11th, 12th grade of high school, and it was a combination of the first person I ended up shadowing through my high school system or program was an anesthesiologist, and through my own network, aka my parents' network, it just so happened to be that both neighbors on both sides were also anesthesiologists growing up. So perhaps it was association, but I got intrigued early on, and then it just continued to build, and that was really just honestly the only thing I wanted to do if I pursued medicine.
Awesome. Thank you. And then I'm going to ask you a question about your residencies, but before I do that, I did want to say that if anybody tuning in has a question tonight for Dr. Letayf or Dr. Kumar, please feel free to enter it into the chat on whatever platform you're viewing this discussion. They will be relayed to us, and I will relay them to the doctors. So we'll be responding to your questions throughout this discussion. I did just have a question come in about residency qualifications, but before we get to that, I just wanted to give both of you a chance to talk in a little bit more detail about your residencies, and then we'll get to this question about the match. So Dr. Letayf, could you just tell us, you mentioned where you did your residency, but if you could talk a little bit more about the kinds of patients that you saw in your residency, and then just talk a little bit about that experience in general.
Sure. So when it comes to choosing a residency program, or doing your anesthesia in an inner city residency program, which I completely recommend, and I'm sure Dr. Kumar agrees with, you get to see such a variety of patients, from very, very sick, unhealthy patients on dialysis with heart failure versus patients that are coming in gunshot wounds, traumas, and it's those type of criteria patients that really you learn the most from. You can sit down and open a book and read about all these things over and over again, but until you get your hands, dirty, as they say, and get thrown in the field, that's the best time to do your learning. And I feel that in any inner city university system, like the DMC, for instance, it's going to be the best, quality education, even passively, because you're just so used to the general patient, health status, which usually is not favorable. So, but you just learn by default.
Perfect. And Dr. Kumar, can you talk a little bit about how your residency helped to prepare you to be a better doctor?
Yeah, so I think I'm very confident in saying that I literally would not have even 1% of the skill set that I do now that makes me a unique or great doctor or good doctor, because Dr. Dr. Letayf said, so there's a difference between going to a inner city or whatever flavor you want to call it, compared to, let's just say, shiny academic institutions such as, you name it, number one and number two of the country. The biggest difference, obviously, everyone is smart. We all read the same book. We all learn and are taught the same syllabus and certain requirements, blah, blah, blah. But what sets, I think, at least Dr. Letayf and I, because I've seen his skill set too, when it comes time and when it matters, not every place you go to in real life do you have every single tool and every single brand named medical supply device. But if you stick Dr. Letayf or I on a side of the road and you give us a pen, like kind of stuff that you see in a movie, I call it scrappy. So really, at the end of the day, unless you're at and forever at a shiny medical institution, you'll be provided that. But 90% of the rest of the country doesn't have that $1,000 special stylet that does X, Y, and Z. And so what makes you I think, a great doctor is problem solving and really figuring out a way to make something work when it needs to work. I think that's my best answer. So DMC provided me that stuff. It's
And
up,
Jay,
yeah,
another thing, if I just want to interject to further allude to what he is saying, again, I'm not saying anything bad about shiny institutions. A lot of places, a lot of the doctors are career driven in research. They like to do that stuff.
of
They don't
course.
want to really get their hands dirty. I'm not that type of guy. I like to be in the fire per se. And there's nothing more humbling when you move to a completely different state like I did and start. I'm 36 years old and I have a set of skills, and I'm not trying to show off. I'm very humble, but I'm just saying this is my everyday life. When you're the guy that everybody calls, where's Letayf? Where's Letayf? For me to come and do, whether it would be a difficult anything. And it's sometimes after you do the difficult thing that you did, you go back and you're like, man, I didn't realize how much I actually learned from the institution I trained at and how lucky
Hmm.
I really am. And again, and I don't try to dog my own teammates because I love them, but some of the gentlemen that I work with come from top notch, but they don't have the same skills, and they'll admit that that we do. So, and it's not just promoting DMC. This is just any real inner
Yeah.
city hospital, because everybody's going to go through the same thing.
So I'll give you a real example so it actually makes sense. So, so if you want to get an idea and make sure someone's breathing, and everyone has seen a face mask, right? That has a little tube that connects to the green oxygen that gets dialed up, the thing. So if you want to make sure someone's breathing, you need to figure out a way that when you breathe out, you get a value of what your CO2 is. So long story short, if you go to a fancy place, you'll have this device that will come with a little tube and it calculates everything for you. Or what Dr. Letayf and I had is you get a regular, everyday dentist mask, right? That you get at, I don't know, that drop down from an airplane, literally that mask. But how are you going to get the number value out of it if you don't have the fancy tube? Well, you can get a clear tube, weave it inside of the venti mask, and connect it to the machine, and you get your number. But that's, I guess, if that makes sense or there's a way to visualize it. But my point is if you aren't provided the best equipment, you figure out a way to make it work, is my point.
So we're getting,
As we say, you MacGyver it.
yeah.
Yes. Yes.
So you learn some good problem solving skills.
Yes. That's a great way to put it.
So we're getting a lot of questions in the chat about pediatric residencies. So I just want to kind of go through a couple of those because I'm sure that the people who have entered those questions into the chat are eager to get answers. And the first one is, as a person who's interested in pediatrics, what were the qualifications that you needed to match into a residency for anesthesiology, especially coming from a Caribbean medical school? So do one of you want to tackle that one first?
Yeah. I mean,
Do you
it's
mean
really
fellowship
just
or residency?
The question was for
similar.
residency, but then there's also another question that's coming a little bit later, I think, about fellowship. So,
I mean, the two things I'll highlight, and then I think Dr. Letayf will say it better, or because he is pediatrics, but it comes down to like, what do you need qualifications? I mean, step scores are way important. I know things are a little different now than when Dr. Letayf and I were doing it because we had a value number and things are a little different, but the concept applies. And then more importantly, audition rotations. That's the most important. And then I think the rest probably better come from you for this.
I guess I shouldn't say this out loud, but I kind of knew I was going to match at that fellowship program the year before because they liked me. I liked them. They're like, we'll take you next year. Done deal. But that doesn't happen to everybody.
Well, there's a
And
reason there's a reason for that though. You worked and you earned it, and yet that's
right.
what they're asking.
So just like it's all about addition rotations, especially coming from the Caribbean. Can't stress that enough. You need to go show your work. You got to go work your butt off. You have to show that you're serious. You got to be the first one there and the last one to leave. And if you do that, you're going to shine more than anybody else. They're not going to care where you're coming from. At the end of the day, we all read the same book and we all take the same exam. And it's who's working harder and who wants it more. And that's the only thing when it comes down to it. And then regarding fellowship.
Wait, no, but just because a school doesn't have a formal relationship with X, Y, and Z rotation doesn't mean it doesn't exist. So
Sure.
so that's important though. Go ahead.
100%. No, I was just saying, I didn't know if you asked this question yet. Was one of the questions, why do you do a fellowship?
Go ahead and respond to that. Yeah.
Okay, well, so there's the romantic answer and then there's the business answer. Romantically, I love pediatrics. I always knew I wanted to do it, so that's why I did it. I didn't realize though until I did it how important it was for me to advance in my career. Right now, there's a in medicine today. There's a lot of APPs, as we call them. Whether you're talking about anesthesia in the form of a CRNA, you got your physician assistants, and you have your nurse practitioners. So you need to find a way to be as strong as possible on paper so that you can get to where you want to be without having to compete with too many people to reach that level. And I definitely believe that anybody at all that does anesthesia should do a fellowship, whether it be in critical care, pediatrics, pain, OB, something that makes you a little bit shinier on paper for job searching and qualification.
And I think this is another kind of related question that's come in through the chat, and that is, what recommendations would you give to students during clinical rotations who are wanting to apply to an anesthesiology residency? And I think you've both kind of addressed that in terms of working hard, going above and beyond, but any other thoughts that you want to
See if you can get on research, work with the residents. You're not going to have the shiniest type of research project, but effort and hard work, that's really what they're looking for. And
I think you would agree too, Jay. Like maybe it'd be good too that when you finish from that rotation, you get a contact there or two.
Absolutely.
You continue to email them, touch base, how you doing? At the same time, you tell them, I'm really interested still. I hope, and then they get it, so you just got to go that extra mile and kind of stay in touch with them, and, things will work out.
Perfect. And then one more question related to residency, and then we can kind of dig a little deeper into your current practice and what both of you are doing. And that is, what is the process like for residency and with affiliated hospitals? So what's it like?
I don't know, Jay, if you agree with this answer. If I understood the question correctly, I think what they're saying is it easier to get into that residency program if you have an affiliation versus not? Probably, because they're just used to the name of the school more, and they see the same white coat badge, but that's not,
maybe this much easier.
It could go, not exactly. It's the same thing. At the end of the day, you still got to work really hard.
Less likely to get denied if they are familiar, but you're not more likely to get it if they are familiar. Maybe that's a better way to put it.
And I only say that too, and I agree with Jay, because those same teaching hospitals also probably have a medical school themselves. So you're going to be doing rotations alongside a lot of the medical students from that institution itself. So you both have deals with that hospital, but there's a lot of competition, and they might want to go with their own. That's why you have to go that extra mile.
And are there any other, this is one more question that popped up, but I think it's relevant to the discussion. And that is, what extracurricular activities or experiences would you recommend a student to have just to sort of beef up their CV during the application process to increase their chances of matching in to a residency?
I think this question really perhaps applies to what they would bring up in an interview. So in an interview for residency, they're not going to be like, okay, Joe Smith, I see that you did this research. Tell me about it. Really, when you walk in, they're like, hi, tell me about yourself. What do you like? They can see what you are academic on paper. And so they really care. Actually, the most common phrase is, we care about what you are as a person, because we need to decide if we want to spend 4, 5, 6, whatever years with this person. That's probably what I've heard the most amongst program directors. But Yeah, something cool that stands you out. So for
Yeah, and I
mine, I was a
definitely would.
DJ,
No,
so that was fun.
he still is a very good DJ, by the way.
Yeah, yeah, just
He's excellent. No, but one thing I remember, this is a funny story. I interviewed once, and one of the co-interviewees, um, I'm not even joking, came bringing a deck of cards with a wand and a hat, like, with like the rabbit, and he started doing magic tricks, and he didn't match. So, there's types of different things that you do and you don't do. But at the end of the day, from my experience, they want a down to earth person that actually has a social life, that enjoys to do sports, that is, doesn't, write. I like to read all the time. They want that person that's dynamic, that's different. And it just makes you look a little bit better and brighter
yeah.
on paper.
It just
Yeah.
stands out because then you're like
Yeah.
that guy that was a black belt or that guy that was a DJ or liked working
Yeah.
on cars, something different.
Well, thank you both. We've gotten lots of great questions in the chat related to residency matches, how you matched into anesthesiology, a lot of interest in this practice area. So I just want to take a moment to pause and let everyone in the audience know that if you do have specific questions about residencies or match, or how you can best position yourself to match into a competitive program like anesthesiology, I believe that in the chat that you'll be able to access some contact information for Patrick McCormick, and he can, from UMHS, and he can answer a lot of the questions that are coming in related to residency specifically and the match. So just want to thank everyone for their questions coming in about residencies. And we are just going to shift gears a little bit and go from Dr. Kumar and Dr. Letayf, your residency experience into your current practice, because we are getting a lot of questions too about what a day in the life looks like for both of you. So, Dr. Kumar, if you could start by just telling us a little bit about your current practice. What types of patients do you see? What does a day in the life look like for you?
Yeah, so um, I am an interventional pain doctor. So my goal and the goal of what my practice is to treat patients that suffer from chronic pain by treating the source of it or the cause of it instead of covering things up with a band-aid or with an opioid, for example. Um, a lot of things change in medicine, and what we knew 15 years ago doesn't really apply today. So what I specialize in is what I say is head to toe pain, and my goal is to treat the source of it, and also with the shared goal to minimize unnecessary use of opioids. So how to treat pain without the use or need or requirement of opioids using modern
Perfect.
day technology, actually.
Perfect. And that actually was going to be a follow-up question that I had for you, which is, how has our understanding of pain and intervention methods evolved since you first started as a resident?
Actually, it's kind of cool because when Andrew and I started was 2014, and it was still the days of, the way you quantify how many pain meds a person takes is what's called MME, morphine milliequivalents, and it just creates a way to be common to share that number to compare. So when we started, and Andrew, correct me if I'm wrong, but we still saw on day one like 900 MMEs, right?
Oh
Um,
yeah.
to give a comparison, the CDC during the opioid epidemic was around 90 was the cap, and even that was high. So by the time we finished in 2020, 2019, 2020, I mean, the most common at most was 30 MMEs. So look at that big difference, and that's a matter of 2014 to 2020. So that's 6 years.
Yeah.
I mean, that's a true fact, right? I mean, literally.
Oh yeah. Easily.
So, and then, so that's one aspect. And what was your other question was about, so how we use modern day technology, and um, that I can go into detail if you want. This is a whole topic on its own, but there's a lot of ways to treat pain instead of covering things up. It's my point. So,
Perfect.
yeah.
Perfect. Great. And Dr. Letayf, can you talk a little bit about your practice?
Sure. So I am currently the Vice Chief Anesthesiologist of our hospital system. So we have two hospitals and the outpatient surgery center. I'm also the Chief of Pediatric Anesthesiology, where we have a busy NICU and we do very sophisticated procedures. And on top of that, I'm also the Director of Obstetrical Services. So I basically cover all the issues in OB, delivering babies and stuff like that. So my days are pretty busy with all those things going on at the same time. At the same time, I'm not the type of guy that likes to be behind a desk the whole time. So I'm always on the go, picking up my phone, answering it. I probably get calls 50 to 100 times a day just for work related things. The nice thing about my job and why I decided to move to where I did was because I love anesthesia to the point where I wanted to also work on adults. I didn't want to just do pediatrics. So this place was perfect because when I interviewed there, they told me we were going to be able to do 50-50. So it's really cool that in the morning you get to do a 1.2 kilogram baby, and then you go have lunch and you come back and you do you do like a big chest procedure or, very sophisticated thing that, needs all these different lines. So, you come back home that same day and you're like, wow, what a day. I was able to do that. And then that in one single day, that's a fulfilling day. And that's why I enjoy what I do.
Perfect. And just a follow-up question, because we touched on this when we had our call earlier, and that is just how pediatric anesthesia is different, how it differs from treating adult patients.
So that's a good question. Jay can answer that too. We both did this, but let's put it this way. Just today, I had an adult patient, and she was telling me, I'm worried about the different types of medications you give her. And then the first thing I tell them is, I'm a pediatric anesthesiologist, ma'am. And she goes immediately, okay, so this guy knows what he's doing and knows that you're super OCD because you need to be extremely careful with the amount of medications, the route that you're giving. You have to understand the physiology of a baby who is not as, they don't have a lot of the same physiological attributes as an adult, obviously. So just like their brains are immature and, they're socially immature, all of their organs are immature as well, including the lungs. If you don't have a lot of time to fidget and you have to be precise and on point, or things can go bad very quickly. So it takes a special team to do pediatric anesthesia, but that's what we love to do. So that's why I did it. Let's just say it's a lot more
Vigilance.
Yes. Oh yeah, easily. And then at the same time, you're dealing with parents that are coming and they're terrified. They're like, who is this random guy I've never met before? And my kid's life is in his hands. I just met him 2 minutes ago. I get it. It's a tough situation, but I love it. What can I say? It's a great field. It's a great area to work in.
And the great thing about anesthesia is you can branch out. So I work with spines and I read MRIs and I use fancy devices and I use an X-ray machine. It's crazy what you can do with anesthesia, but
Yeah.
we are so great with our hands and our needles and going from point A to point B and using ultrasound and imaging guidance. It's like second nature almost.
That's perfect.
I was
Sorry, go ahead.
I was just saying it's funny he just said that because I was just thinking that an hour ago. I was like, what could I say about anesthesia? And it's just like it you can stem into so many different areas in our field, and not a lot of people know that you can do that. And it's amazing because you just become so multi-talented and able to do so many diverse things.
Great. So to build off of that point, and I'll throw this out to both of you and you can jump in, but just curious if you'd be willing to share just an interesting story about a patient that you treated or a case that you handled that, thinking back to when you were in med school that you would have been interested to hear about.
So I have a good one. I just did it last Wednesday. So it's fresh. So it's a patient of mine that's been my patient all the way when I was still at Duke. So, more than 3 years now. She I first started seeing this patient, and she was on, high dose opioids from whatever prescriber or provider rather prior. She suffered from ESRD and end-stage renal disease, and it kept progressing over the years, and she had to go on dialysis. So one of the side effects or associations or what can occur in the process is you can get neuropathy, which is a buzzword for numbness, burning, shooting, tingling, pins and needles. So it got so bad where she can't sit through dialysis because of the pain. It was unbearable. So now you have your nephrologist that's on board that is also, you're trying to coordinate as a pain doctor or even an anesthesiologist, that you have to work together as a team. That's really the best way in medicine is team approach. So long story short, you got to figure out a way. But when you have renal issues, you have your platelets may be normal, meaning 250,000, whatever. But the quality or the function of those platelets are not up to par, meaning, so it's called, the patients become uremic, and that makes the platelets present, but not functional really. So when you do any spinal procedure, you have to worry about bleeding. You can't bleed around your spinal cord because then a lot of bad things happen and so on and so forth. So how can I help a patient that's now tolerant and not responsive to pain meds? They can't have any fancy device in their back to help their feet that you can maybe see off social media or whatever device or TV. And now they need ESRD to live. Sorry, they need dialysis to live because they're in line for a transplant. So how do you figure out a way? Well, in this case, to summarize before Andrew tells you the story, I did a bilateral, which means both sides, peripheral nerve stim implant, and I put one piece of sewing thread on the right leg using ultrasound at the sciatic nerve, and one piece of thread on the left leg using ultrasound on the sciatic nerve, and she gets these two removable stickers. So now she has 95% pain relief without having to take pain meds. She can sit through dialysis. Her nephrologist is happy, and this changed her life. It's a cool story.
That's incredible. Yeah.
Wow, man.
Very cool
That's what I
story.
say.
Very
Oh,
cool.
and then no surgery center would allow her to come in because she had ESRD, and that's where the medicine and politics of medicine comes in, where it says it on paper, even though, so if they have a certain disorder, they may not be able to get a surgery at a center because they're afraid of it will cause issues, sequelae, and they have to call ambulance, it'll be on the news, the whole thing. So now you get to figure out where to put the patient to get the implant done. That was another endeavor. So everything worked out, but
That's a great story.
One of my the joke about me is that I always find myself in the weirdest situations, and Jay would agree with that. But it's just to give you a 3-day period without exaggerating, and just to show you how blessed we are as anesthesiologists to be able to do what we do. It was a Tuesday, middle of COVID. I don't want to name names. I'm scared I get in trouble with saying this story, but I won't say too much details. But let's just say we were doing a neck surgery where we have to place a little airway inside of the neck because the patient can't breathe well. So it's called a tracheostomy. The surgeon who did it was excellent, but I guess the patient's anatomy was all weird, and the patient started bleeding profusely, just profusely bleeding. I mean, movie theater type of bleeding. And I immediately decided that it would probably be a good idea to put a sterile glove on my hand and stick my finger in the patient's neck, because the surgeon, we don't have residents, or we do, but at that, we don't have surgical residents that work with that specific surgeon. So he needed a second hand. And I was like, okay, I'll just do it. So I go and I stick my hand in, and we end up becoming heroes, and anesthesia is great. And oh my God, the next day, my pregnant wife at the time was at home, and she sends me to Whole Foods. And mind you, this is Tuesday, so we're a Wednesday, and I'm driving and I see a big car accident on 95 in Florida. And me being me, I just kind of like looked to see if anybody needed any help. And I saw a bunch of bodies that looked like a family all over the ground, and it was a horrible accident. So I get out of the car, and I see some lady trying to do CPR on a baby who probably was around 3 to 4 months old. And I told them that I am an anesthesiologist, and immediately they're like, let him through. So I go in, and I was actually able to intubate the baby on the highway like laying flat, which is extremely difficult to do. And at the same time, the lady that knew what I did was a neonatal nurse at a hospital, and there was a cardiologist. All three of us were working on this family. And then the next day I come back, everybody's like, oh, great job. We heard about it on the news, this, that, and the other. There's a code blue in the cafeteria. I was like, huh? And I run to the cafeteria, and it's the guy that makes the hamburgers, the greatest guy ever. He codes, and I end up intubating him. This is 3 days in a row. And every time I call my wife telling her, you have no idea what just happened. She wouldn't believe me. And these are all just they actually happened very accurately. So again, if you're ever put in a weird situation, you have this set of skills to be able to get you out and to help save a life in our field. That's for sure.
Well, those are some incredible stories. And I know we've been getting a couple of questions in the chat related to kind of day in the life. What does a typical day look like? So maybe rather than talking about these amazing stories about what happens on the side of the road, if we could direct you, Dr. Letayf, to talk about what is it like working in a hospital setting. So like for the people who are tuning in, could you just kind of walk us through a day in the life as an anesthesiologist that works in a hospital setting? What are your hours like? What's, how much time are you in the hospital? How many hours are you on call?
So I'll start. I work a lot more hours than your regular anesthesiologist, but just because of my leadership position. But a person that doesn't, the usual hours are going to be anywhere between 6 to 3 p.m. or 6 to 6 p.m. A lot of hospitals now are going and doing something called a night float system, which basically is you divide the 24-hour shift between two sets of teams. You have a day shift team and you have a night shift team. The day shift team will come and work until 6, and then the night shift team will come and take over at 6, which is nice because you get to sleep in your bed every single day if that's what you want to do. So yeah, I get to work really early, and I have my coffee, and I go and I meet my patients. And one of the most important things too is, again, we take this very lightly, but you're not the surgeon, you're the anesthesiologist. You're meeting the patient for the first time. They've never seen you. They have no idea who you are. You could tell them your name is John something, and they don't know if that's really you or not. So you have to have a perfect rapport. You have to be nice to them. So you go, you make a couple of jokes, you do your pre-op assessment, and then you take the patient to the operating room, do the case, and come back, and just keep doing that until your shift is over. So it's a lot of, I would say 20% of an anesthesiologist's day is actually doing paperwork, meaning interviewing the patient, making sure everything is perfect. And the rest is actually in the operating room, making sure the patient's breathing well and staying alive. And the other nice thing about it is that you don't have hours where you're scared that somebody's going to call you in. It's beautiful in anesthesia is that, when you leave that hospital, you're done. You don't have to come back. So you can go and do whatever you want to do and just come back in the next morning. You're not on call per se, like a surgeon is, or, other fields.
Perfect. And how would you characterize your work-life balance for someone that's considering anesthesiology?
I love my work-life balance, but I also love my work. So for me, work is life in a way. Yeah. So I enjoy being there. I enjoy my hours. I don't even look at the time, which if you looked at my residency and you asked anybody in residency, they wouldn't believe that, what I just said. But it's amazing how times change. But I have time to be with my family. I have time to work. And when you enjoy what you do, it's really not work. So it's a combination of the two. I always have time to work out. I love going to the gym. I love, hanging out with my friends on the weekends. Once every 6 weeks, I have to work on a weekend. So, it's a perfect life to work balance, I would say. Probably not as nice as Jay's life because he doesn't have to take call or do any of the late stuff, right?
Well, there's two answers for that. Depends if you are a outpatient pain doctor in a hospital, a pain doctor in a hospital, outpatient pain doctor that's employed, such as like my old job at Duke, or having your own practice, because being employed and having your own practice are two different things because you throw in the whole business aspects of stuff. So
perfect.
Yeah. It's much different than yours.
So that's what I was going to actually follow up with you, Dr. Kumar, because it's nice to have both of you in this discussion, right? Because you can offer different perspectives on different career paths that people can take in anesthesiology. So you've got Dr. Letayf, who's working in a hospital setting. And then Dr. Kumar, could you tell us a little bit about your like a day in the life of someone that has a private practice? What it's like, what kind of hours you work?
Yeah. So I'll give you two because private practice, that means two things. Private practice that's yours, and private practice that you're employed at. And so it's important to make that distinction because it changes the answer. But so, if you are employed and you're a private practice doctor, I mean, it's great. You have no weekends, you have no call, you go to work. If somebody calls in, meaning your staff, somebody will be there to fill in that gap through whatever employer there is, right? Your job is to see patients and diagnose, evaluate, and provide a new way, a different approach that they have not been exposed to. So it's cool. You work with neurosurgeons, you work with neurosurgeons very closely and orthopedic surgeons because you are also coordinating because pain in pathology may or may not always come together. Now, if you compare that to a private practice person that owns their practice, a little bit different because the things that they didn't teach you in medical school, such as Google ads or Yelp ads or social media marketing or even the right credit card swiping machine to be honest, those things you don't get taught that, but you pick up quick if you're the person that is going to go down that route. And so the phrase I like to use is every day, new day. So, for example, Friday, I had my first employee that I had to, unfortunately, we had to part ways for numerous reasons. But, it's important as the physician to maintain the medical aspects, the medical advancements, the medical evaluation side of things, and be a great doctor. And on this hand is the importance of making sure the lights stay on.
Yep.
And so it's very unique opportunity that you can also branch out in. And yeah, being an anesthesiologist, I think, gives you the problem-solving skill set to be able to go down that endeavor if you choose to.
I think that touches on a really important point is, I think for a lot of people tuning in, they have these they've long had these dreams of becoming a doctor, and there's so many different career paths that you can take, even, within a very specialized field like anesthesiology. So I think it's important to kind of raise those questions that, there's this ideal of having your own practice, but then there are also the realities of having to figure out the credit card machine and hire someone to do your social media or doing it yourself. So it challenges you in some different ways that you might not have considered. So I think that's an important point. And kind of related to that, I'm sure something else that's top of mind that came into the chat earlier in one of the questions, just scrolling back, was really just about compensation and what compensation looks like as an anesthesiologist compared to maybe some other specialized fields. So I don't know if either of you want to kind of respond to that question.
Sure. I think I'd probably
standard deviation.
Yeah. Well, anesthesia historically has always paid well. That's for sure. But like anything that is rare is worth more. So when you're graduating a lot of something, the compensation goes down and vice versa. Today, as we are, for instance, in South Florida, it's extremely difficult to find an anesthesiologist. Extremely. You'd be surprised. You'd think South Florida, Miami is the place to be. If you go on a website called gaswork.com, which is where we, look at jobs and stuff, if you see the amount of need for anesthesiologists, it's unbelievable. So as we're seeing incrementally, the already, I would say quite lucrative compensation is becoming even more lucrative because they are trying, one way to bring people to work is to pay them more. So you would definitely live a very comfortable life. Not going to see you turn into a multimillionaire, but you will always feel rewarded, I would say.
And then if you want to go to the middle of nowhere, meaning west coast of the United States,
Yeah.
pick a random city in Idaho. I don't know. No offense to anybody in Idaho, but just anywhere. The more remote the place and the less any provider, the higher you'll get. But that's where you factor in, is money important or is life important? And that's to each their own.
Yeah.
Yeah.
We actually, just putting in a little plug here, we actually did a live stream event focused on rural medicine. And one of the key takeaways from that discussion was that for people who are willing to practice in more rural or underserved areas, tend to get really good compensation as a way to attract doctors. So for anybody who's interested, I'll just put a little plug in here. Anybody that's interested in learning more about that, you can visit the UMHS YouTube live events and meeting page and look at that discussion
And
about
Megan,
rural medicine to
it's
learn
not just financially, it's also, which is extremely important, the vacation time you get. So not only will they pay you a lot, they'll tell you, hey, we'll give you 15 weeks of vacation. So you talk to yourself, you're like, wait, so I'm going to get paid a lot, and pretty much every week, every month, I could take a week off and travel wherever I wanted. So you get that a lot in anesthesia as well.
On the contrary, though, if you have your own practice, if you take off, you're also not only you're paying for your vacation, but you're paying or you're losing revenue.
You're losing your income that week.
Yes. So, you know, night and day how things change, and whatever path makes you happy is what matters.
Yep. Question that just came into the chat: any national conferences within anesthesiology that are worth attending or submitting abstracts for medical students? For example, ASA.
ASRA. Yeah, ASRA is probably number one. ASA used to probably, it's too big, maybe. Both important. You have to do both. But ASRA number one, number two ASA.
What about MARC? Is it called MARC?
That's regional.
Yeah, but that's also something, because, like, in my opinion, if you're trying to get into an anesthesia department, the smaller you would apply, the smaller you would send, groups to, the better your chances are to stand out. But I forgot what it was called. Was it called MARC or
the Midwest Anesthesia Residency
Regional Conference? Yes.
Regional. Yeah. That one.
Yeah.
Well, we're coming close to the end of our time. I just have one or two other questions, then we'll see if we get any other questions from the chat. The first one is really just general advice for anybody considering going into anesthesiology, just sort of general thoughts, input.
So I've been waiting to answer this question. So I find it extremely important to address this, not just as an anesthesia residency spot, but as anything spot. Okay. And this is pertaining to anesthesia. This is pertaining to Caribbean medical students, especially my favorites at UMHS. UMHS, if whoever's listening, do not think that you can't do something. Okay. Me and Jay are right here on this Zoom chat, and we are a living example that anything is possible if you work hard. The worst and the biggest disservice you can do to yourself is to say, oh man, I'm never going to be able to match in that. I'm never going to be able to match in that, or I'm never going to be able to become a doctor. If you think that way, don't even try. But if you have perseverance, believe in yourself, don't give up, and you're going to get a lot of negativity along the way, believe me, and you just keep with your goal, and you're going to reach your goal. You're going to reach your goal. I promise you. You just have to be perseverant, and you have to believe in yourself. You have to have a good support system, and get the whole stigma of, I'm a Caribbean graduate, I'm not going to be able to go, because again, I guess I'm humbly speaking, I'm one of the best in what I do in this region as a whole, and I'm proud of it. And I'm proud to say I came from the Caribbean, because it gave me a chip on my shoulder, and I wouldn't have changed a thing, because this is what made me who I am. And I'm very passionate about this topic, because I hate to hear that students that could have made it didn't try, or thought they couldn't reach certain levels because of where they're coming from. It's not about where you're coming from. You're reading the exact same books as your peers. You're getting in the exact same hospitals as everybody else. You just got to work harder. than they do, and you will make wherever you want to do. And that's my like
Mm-hmm.
motivational speech, but that's actually what I really do believe in.
I think that's a great
It's a
message.
fact. Everything you said is a fact. Yeah. And
Yeah.
that applies to me. Everything he said applies to me 100% too.
And you need to have friends like Jay. Honestly, like you need that guy that's like, man, let's dream a little bit. Let's say we wanted to do something and let's
Yeah.
do it. And let's push each other. And how did you do this? And what did you do there? And how did we do that? That's what you got to do. You need that support system, and you made it. I mean, we didn't make it by mistake. And not only have we made it, we actually are excelling in our field, and much better than a lot of the people that went to your fancy shiny medical schools in America. So again, we're a living example of just work hard and believe in yourself and have a good support system, and that's all it takes.
Yeah. Actually, I was faculty in teaching the Duke Pain Medicine Fellows.
There you go.
Good. Any other thoughts about just anesthesiology specifically as a practice area? Dr. Kumar, any thoughts, exciting advancements, words of encouragement for people that are considering a career in anesthesiology?
You know, here's a fun game to play. If you're at a table with pre-med students or whatever, doctors one day, and you be like, hey guys, you know, if you had to pick one person next to you, or like if you, God forbid, needed one doctor next to you in an emergency situation, who would you pick? And you have an ER doctor or an anesthesiologist, whatever. I mean, even if they don't want to say it out loud, the answer is an anesthesiologist, period. I mean, that's just common sense. So I think that's my best statement that I can make, is that it's a great field. If I had to do it all over again, I still would do anesthesia. So that's how you know that's how you know you truly like what you do. And everything I've gotten and achieved thus far is definitely related to anesthesia to some extent and the skill levels associated with it. So yeah, I mean, it's a great specialty.
And Jay, would you
It's
agree?
cool too, you know? It's like a cool specialty.
100%. I also think, probably not you, Jay, because you opened up a clinic now, but one of the things I like about anesthesia is that nobody really knows what we do. So you don't have to answer a lot of questions. Literally every patient I see, I go, yep, I'm going to be your bartender today. And they're like, okay, just make sure you wake me up. Okay, done. That's it. That's every single patient. It's the same story. And I like that, because if they actually knew what I was doing and the importance level I have on their life, they would be really, really worried, really, really scared. It's actually the really, really educated patients that know exactly what an anesthesiologist knows that is the most difficult patient. So that's my 2 cents on that as well.
Perfect. Well, we are coming up on our time. Thank you both so much. We've had incredible engagement from our audience tonight. So I just want to thank everybody who has tuned in tonight and who has submitted questions through the chat. I hope that we were able to answer all of your questions as they came through. We know that there might be some follow-up questions that you will be thinking about. And so both Dr. Letayf and Dr. Kumar have been kind enough to share their email addresses with us tonight. I think those are going to be entered into the chat. So if you have any follow-up questions for them, if you have any questions about networking or, about their practice, feel free. They were kind enough to offer up their email addresses so you can reach out to them. Just want to thank both of our panelists, Dr. Letayf, Dr. Kumar. Thank you both so much. We know that you are both very, very busy people, and we appreciate you taking time out of your schedules to share your experiences and your expertise with everybody who tuned in tonight. So thank you.
Our pleasure.
So much.
No problem.
Thank you. Anytime.
And this discussion has been recorded, so it will be posted on the UMHS YouTube page under the live events and meetings. So if you want to go back and review any of the discussion from tonight or share it with any friends, feel free to do so. It's also a great resource, like I mentioned earlier, for past discussions. So feel free to visit the YouTube page. But again, thank you both, Dr. Kumar, Dr. Letayf, for tuning in tonight. Thanks to our audience, and have a good night. Thank you.
Thank you. Have a good night.
Okay. Good.